Hi, everybody. This is Dr. Wajiha Javed, and I'm joining from the Getz Pharma platform. I invite you all to the series of webinar or web talks that we'll be hosting every couple of days with international experts that you would want to hear from and listen from. Let me introduce myself. I am the head of public health and research at Getz Pharma. And Getz Pharma is bringing this series of seminar to you, which is going to be in a question answer format. And it is going to be with academics and people from different walks of life who are experts in that particular area. Uh, we're not hosting it particularly just with doctors or only one particular cadre of workers. It's going to be across different walks of life, with economists, with politicians, with environmentalists, with health experts, etc. And we'll have a different topic each week. Our audience is majorly who's going to be looking into this are going to be policymakers, academics, and students from different universities. We'll have different countries join in with us. Uh, During this first episode, we have subject specialists with us from Kenya and Philippines, who I'll shortly who I shortly will introduce to all of you. And we have different social media partners who are universities from within Pakistan who would be hosting this series of webinars with us and playing it live on their stream. So today we have with us IBA University, Habib University, IOBM. We have Karachi University, also who's our social media partner. We have Zabist. We have Dow University of Health Sciences. We have National University of Medical Sciences, NUMS. And we have Ghulam Ishaq Institute of Engineering and Science, GT. Now, let me introduce you to my panel of experts here. I have with us Dr. Troy today, who's joining us from Philippines. And Dr. Troy is a public health epidemiologist who's based out of Philippines. He has done immense work in the infectious disease field. He's worked immensely on SARS, on the avian influenza, on MERS. He's worked previously with the WHO, CDC surveillance and response. He's also worked with EPI. Within Philippines, he's worked with the Department of Health Office and the Philippines Senate Committee on Health and Demography. So welcome, Dr. Troy, to our program, and we hope to learn a lot from you. And if we get any live questions in the middle, we'll be taking them also towards you. Our second panelist for the day is Dr. Philip, who has joined us from Kenya. Dr. Philip is the Deputy Director of Medical Services in the Ministry of Health, Kenya, and he's also on the COVID-19 task force within Kenya, and he's right now he is working with the Ministry of Health. He has over 30 years of experience in the field of public health and epidemiology. Also, we will have a third panelist join in who might have some technical difficulties because he's in a remote area at the moment. So he might join us in sometime late, but I would like to introduce him. It's Dr. Saad Khalid Niaz, who's a leading gastroenterologist in Pakistan. He's also a receiver of the Tamgha Imtiaz, and he's also worked massively in the field of public health and was a very key player for COVID-19 within Pakistan. Today's session is going to be, so literally the title is Public Health Failures and Lessons Learned for a Post-COVID-19 World. But to break it down into more specifics, the first half of the program is largely going to be around what went wrong. And we will be looking into country examples from Kenya, Philippines, and Pakistan. But I would also like my panelists to generally look into global issues that we also had during this pandemic and where they felt we went wrong and things could have been done differently. In the second half of the program, we will be talking majorly about the future of this world after COVID-19 has finished. So the world is not going to be the same as it was before COVID happened. That's what we're all talking about. But we would love to hear from our experts that what lessons do they feel we should have learned from this? And if God forbid this was to happen again, what would we have done differently? So I'm going to open the floor today. Thank you very much. Thank you, Dr. Troy. Thank you, Dr. Philip. Thank you, Dr. Saad, for joining us in today. So my first question is going to be a very generic question. And again, as you all know, cases are overall declining in different parts of the world. Uh, we are experiencing lesser number of cases per day on a daily basis. Mortality is decreasing, but there are still a lot of pockets which have a high disease burden as well. There are countries who are experiencing a second wave of COVID-19 as well. There are countries who are experiencing reinfection also as well. There's a lot of debate going on about vaccines and whether we see an end to COVID-19 by the end of 2020. So, my first generic question is to all my panelists. Do you think COVID-19 is going to finish by December 2020? Or do you think it's going to have more of a seasonal reappearance every year? So, I open the floor.
Yes, good evening from the Manila. This is Dr. Troy Gepte from the Philippines. Um, Good day to Dr. Wajiha, Dr. Philip. It's still daytime there, but anyway, here it's already nighttime. But here we are about to embark on this program. I'd like to just say that here in the Philippines, we are still very much within the ongoing pandemic. So if we were to be asked if we see a near completion of the pandemic by this year, by the end of this year, I think we're still expecting the pandemic to go on to continue until at least the middle of 2021. We're still seeing a lot of cases here, particularly in the capital, in what we call Metro Manila and nearby provinces. So the cases are still going up, and I think we're still learning from how we can manage the influx of these cases, not just here in Metro Manila, but also in the other provinces. We have a big part of our population that is working outside the country. We call them overseas Filipino workers, and when they come home, they will eventually end up in their hometown. So we need to eventually try to make their capacities at the local government level be stronger so that they can foresee how they can quarantine and isolate these cases and contacts that might end up in their own municipalities or their cities. So I think we still have a long way to go, and we're still trying to learn as much as we can from updates about the vaccine. But so far, we have been somewhat semi-successful, quasi-successful in carrying out the surveillance necessary for us to identify cases, to detect cases, and also to exercise precautions by having our non-pharmaceutical interventions, such as the wearing of masks, face shields, having proper physical distancing, and enough guidance and advisories, not just for our communities, but also for our workplaces. So we are still very much in the battle, so to speak.
Thanks a lot, Dr. Troy and the other colleagues here in Kenya. I think we are still not out of the wood of COVID-19, and we should expect as a globe, this is not a problem which is going to just be wished away. And as we have had other pandemics like the 2009 avian influenza pandemic, we're still isolating this strain of the virus within the population where we are doing sentinel surveillance. So we expect, even when the pandemic dies off, we expect to still continue isolating cases of COVID-19, even though they may come in a mild form after the populations get immunity. And we are anticipating it to start behaving like the common influenza and other common cold causing viruses. Thank you.
Okay. Thank you, both of you, Dr. Troy and Dr. Philip. So my next question is that if you could highlight three major mistakes that were made at a country-specific level within Kenya and Philippines. Before you do that, if you could also give us a little summary of how your country is doing at the moment for our listeners to understand, because we're catering to a global audience.
Yes. For the Philippines, we are actually near around 180,000, maybe a little bit more, number of cases, confirmed cases. So far, we have had about 2,000 deaths. The majority of those cases are have been recovered already. So that's a good indicator for us. Unfortunately, we still have a deluge of patients in our hospitals. So we have some thing to monitor in our critical care utilization for the ICU beds, the ventilators. Um, uh, so we still have to prepare our healthcare system, um, and we really have to find a way to learn from what is happening so that we can further strengthen our capacity to handle this pandemic.
Mhm. Dr.
In,
Troy, like I said,
in
if you
Kenya, we
could,
are now at about, yes, can I go on?
Dr.
No,
Philip, you
can
were
you hear
saying
me?
something? Please carry on.
Yes, yes.
Yes, please,
In
please,
Kenya, we
please
are at about
proceed.
29,000
Yes, I can.
cases with about with about 500 deaths. The outbreak, we have started seeing a decline in the numbers, and we have actually instituted most of the measures the Philippines have done, including the public or social measures like social distancing, masks, and sanitizing, the community responsibility, reporting any suspect cases to the facilities. We have also had curfews, targeted lockdowns. We have had closure of borders. Community engagement has been actually a big chunk of the response we have done, and some of the teething problems, some of the mistakes which cropped up when this problem came is in the coordination. In the coordination process, the coordination was weak, and it did not realize the whole of society approach in the initial stages. So by the time they realized this pandemic is going to affect all critical sectors of the economy, it was a bit too late. And when they put in place the whole of society approach in preparing and responding to this, it was a bit too late, and a lot of ground had been lost. So in future, I hope nations will think about the whole of society approach in pandemics like this. It's not only a health issue. Then the other thing is, when nations start to prepare for this, you don't need to create new structures. Use structures which have been there, which have been proven to work, so that you can write on existing structures which have worked for other outbreaks within your countries. Don't try to create new ones, because before they adapt to the current and to the problems at hand, then they'll have lost quite a bit of time, and this means loss of lives. This is not acceptable. Then you don't need to go and bring on new folk, because probably you feel you are keen, or they are new brooms who may sweep cleaner. Use the folks who have been there, the health workforce which has been there, and build on that, so that at least you can enhance and get capacity for new ones who you want to put in place. So don't make mistakes of trying new brooms which you don't know whether they know how to sweep or not. Thank you.
Good. That
Dr.
was a good
Wajiha.
summary. So we have, yeah, Dr. Troy,
Yes,
please.
if I
I
can
think you wanted to
continue
say
with
something.
what Dr. Philip mentioned, we also have that kind of mindset that we don't really have to reinvent anything. We actually have learned a lot from previous outbreaks, and we had the H1N1 pandemic in 2009 and 2010. So that really gave us some time to really come up with a good plan, a good strategy, so that we can anticipate what can happen in a pandemic. But nevertheless, this pandemic of COVID-19 really happened, and we should try to learn as much as we can. For what happened early in the pandemic here in the Philippines, we really should have poured more resources, more manpower, more facilities for our laboratory detection, our epidemiologic surveillance. The first initial cases were something that we missed, and we were really at the loss of how to come up with good contact tracing, which is very, very critical for us in coping with the pandemic. So I think, as for what Dr. Philip mentioned, I echo that same sentiment that we really have to learn from what happened, from all of these limitations and the vulnerabilities in our healthcare system, and we have to move forward. Yes.
Hmm. Okay. We also have with us Dr. Saad. Dr. Saad, if you're able to hear us, would you like to talk about three major mistakes, I would say, that were made within Pakistan for COVID-19 and its handling? Were resistant. Are you able to hear me?
I cannot, I'm sorry, I cannot hear you.
Okay. I'm going to repeat the question. So I've asked my other two panelists. Now can you hear me? So, Dr. To my other panelists, I had this
A little
question.
better.
That
I don't know if you can you hear me? I'm sorry, but I think this sounds really, the voice isn't good enough. At my end, I can't hear you, but I don't know whether you can hear me or not.
I can hear you perfectly fine. So my question here was, what were the three major failures that were made by Pakistan in terms of policy for COVID-19? So my question here was, what were the three major failures that were made by Pakistan in terms of policy for COVID-19? So my question here was, what were the three major failures that were made by Pakistan in terms of policy for COVID-19? Okay, so I think we might have some reception problems here. So let me talk a little bit about the Pakistan scenario. So in Pakistan, one of the things that we did here was that we only tested individuals who had symptoms. So we only had a symptom-based testing approach, due to which we were not able to very, easily highlight pockets of infection, because when mass screening was done at a large population level, we saw a lot of cases that were asymptomatic or that were mildly symptomatic, and hence, because they were asymptomatic or mildly symptomatic, they did not go out and did not get tested. So, had we not tested them incidentally, they would not have known that they were COVID-19 carriers, and hence they continued to spread it around. I would like to ask Dr. Troy and Dr. Philip, what kind of testing model was employed in Kenya and Philippines? Either one of you can go
Yeah.
first.
Yes. Thank you, Dr. Wajiha. Dr. Philip, I'll go ahead. For the Philippines, we also did the same thing. We were only testing for symptomatics, but sometime in April, we actually got updates from other countries that when they were testing for their population, those who were not symptomatic, those who were asymptomatic, it turns out that there were really a lot of confirmed cases among those who didn't have symptoms. So this made us think that we were really dealing with a different kind of virus. It's so much transmissible than the other kinds of viruses that we've had, but this time there's a big chunk of the population. There's a big proportion of the population that will not manifest any symptoms, but yet they might be carriers. So we tried to increase our lab capacity from a few labs at the outset of the pandemic, and now we have around 80 laboratories all over the Philippines, mostly centered in the cities, but we are still trying to find a way to increase our capacity in the countryside. So we have laboratories, facilities, manpower, training, and also the important logistics and supplies that are needed so that we can ramp up our testing.
Mhm. Dr. Philip?
Right. In Kenya, in the initial stages, of course, we used to test the positive, the ones with signs and symptoms. But for every case who tested positive, we used to go and do what we call contact tracing. And initial stages, we used to test all the contacts, whether symptomatic or not. And we realized at that point, a lot of the contacts who had been asymptomatic actually tested positive, and these were isolated in the initial stages before the numbers became too big and we could not take care of them anymore. Thereafter, we did what we called targeted mass testing in areas like in the capital city Nairobi and the other big city in Mombasa, where we had a lot of positive cases. We went to the communities and requested them after educating them to take the COVID-19 test. And during this targeted mass testing, actually, we realized a lot of the, about 80% of those who were tested and tested positive were actually asymptomatic. This brought a bit of a problem because now there was the requirement that when you are you test positive, you are isolated. And this brought a lot of clients to the isolation facilities, which outstripped the available isolation facilities in our country. So with that is when we realized now we need to think of another mode of actually managing the asymptomatic or mildly symptomatic cases. And in Kenya, we have started what we're calling the home-based isolation and care. We are trying to decongest the health institutions and by caring for this asymptomatic or mildly symptomatic positive COVID-19 cases at home. So these are the initial lessons we learned. And initially, we only used to have one testing laboratory at the national level. But by the end of the second month, we had actually increased the capacity to at least about 20 laboratories, which were testing across the country, being controlled by the national laboratory level for quality control and quality assurance. So this COVID-19 has actually also helped us to expand the capability of testing for novel influenza respiratory pathogens, which is something which is good. Thank you.
Great. So another question that comes to mind is that there are different kind of lockdown strategies that different countries looked into. For instance, Pakistan went in with a whole site lockdown, which included schools, universities, shops, workplaces. Everything was a massive lockdown in the beginning. Then there was a relaxation, and then there was a second round of lockdown that happened. And schools would be opening up after 6 months, in almost like the next 2 weeks or so. We experienced an initial first wave, which was massive, which actually brought down Pakistan to the second number in the list of countries which had new number of cases per day. And we remained on number 2 for at least 10 days or so. But then we started declining. And we're in this phase where people in Pakistan and experts in Pakistan are talking about the fact that Pakistanis, the population, has now somehow reached the herd immunity threshold that we, in our language, call the HIT. Now, Getz Pharma, from where I belong, we carried out a survey on around 25,000 individuals, and we did a sero-prevalence, and we found out that the prevalence of people who have antibodies, whether they're symptomatic or clinically asymptomatic, was around 20%. Now, given this fact that we're only at 20%, but yet very few number of cases are coming, Would you gentlemen want to highlight a little about how your country specifics are uh, according to the curve that you're having, according to the number of new cases you're having, and whether there is an element of immunity being introduced? Because in Pakistan, we seem to have reached the herd immunity threshold, but at a much lower prevalence than what global experts feel that it's at 60%. But at 20%, it feels like Pakistan has reached that threshold. Now, it's a very debatable question because we don't know whether COVID immunity is going to stay for long or not, whether we will have a second wave or not. But we also found within the sample that Pakistani population is very heterogeneous. And if the population is heterogeneous, and you both are epidemiologists, and we have a lot of epidemiologists watching this program also, that if a population is heterogeneous, then their herd immunity level is reached at a much lower level as compared to a higher level. And if a population is more homogeneous, then their herd immunity level is higher. So, Pakistan being a heterogeneous population, we seem to have achieved the herd immunity at a much lower prevalence. Same is the case with Sweden, same is the case with a lot of other countries. But New York here is an exception. At 20%, they did not stop having new cases. They were not able to have herd immunity. So, would you like to talk about it by giving your own country-specific examples, and then globally also, and what you feel about the whole herd immunity concept? We can't hear you, Dr. Troy. You're muted. Dr. Troy, you're muted.
Can you hear me now?
Yes, we can.
Can you hear me now, Dr. Wajiha? Yeah. Dr. Philip, if I may, I can go ahead. For the Philippines, we actually had a 2-month lockdown at the very start, and then we somewhat relaxed our lockdowns towards June and July. But starting this August, we tried to go back again to a harder kind of lockdown for 2 weeks. This is our first day actually today when we tried to relax again our community quarantine, or what we call our general community quarantine. So for this particular lockdown, we're trying to come up with different kinds or levels of lockdown, and we're trying to make people go out to the community, to the workplaces, to the establishments slowly, gradually. So we're adopting a slow but sure approach, although it's taking us like 4 or 5 months already. But anyway, about the other topic, we have a very, very active medical community. So we have a lot of doctors, medical research who are weighing in specifically about the immunity or the herd immunity. So we are trying to get the consensus from a lot of doctors. We have documented some cases where we have reinfections here in the Philippines. So we're still learning a lot from that. But what we have seen from research studies and from people who have come down with the COVID infection again is that apparently their first infection was very mild, and we are thinking that according to the medical literature, probably a lot of people really didn't have that much of the viral load for them to really have the immunity to develop, so that they can try to have a substantial kind of resistance against the COVID-19 virus. So we're still a bit ambivalent about how we are to proceed, except that we just have to stay put with our strategies of having the testing, the contact tracing, putting contacts in quarantine and confirmed cases in isolation, and then trying to manage them. So we are really focusing more on the healthcare system, and it will just be something that we need to document or to conduct research studies on with regards to this herd immunity.
Good, great. Dr. Philip?
Yes. For Kenya, we undertook some targeted lockdown. We did not lock down the whole country. There are about four regions. We have about 47 regions in Kenya, and 4 regions were heavily affected by this problem. So we had targeted lockdown of people not moving out of these 4 regions for about 1.5 months. Then this was lifted after we realized that we felt a lot of the transmissions which were moving from there had been contained. Then the other measures which we took, we still have a ban on in Kenya for social gathering. Actually, there are no we have completely minimized the gatherings in churches, in mosques, and it's just about last week that we started opening the churches and the mosques slowly with a lot of emphasis on social distancing and hygiene and making sure if a mosque was holding 10,000 persons, now it can only take a maximum of 1,000. We still have school closures, and we probably may go up to next year before schools open again. This is a form of banning of social gathering. And we come to the herd immunity in Kenya. We have not done specific studies on the herd immunity, although we have done some sero-prevalence surveys of the COVID-19 in Kenya, which we feel probably by the end of this year, we should be able to do a more serious sero-prevalence survey and look at the level of antibodies in our population and gauge whether these antibodies are protective or not. We are getting the support of international bodies like the CDC of the US, WHO, and USAMRO, which is an American military platform for medical research. So on the herd immunity bit, we are praying we get this to this level sooner than later, because we hope the herd immunity which we are going to get will be long lasting and be able to protect our people from further suffering from COVID-19. Thank you.
Great. Another question, again, a very controversial one, and I would like to ask you both, and I'll give the Pakistan perspective. Why do you think mortality has been so low in countries and then it has been so high in other countries? For instance, in the Pakistani perspective, we had a lot of cases, but our mortality rate never went up more than 2%. The majority of our patients were majorly asymptomatic or mildly symptomatic, but only 2% mortality. That could be because we had more of a youth population. We have almost 60% of the population who is in the youth age group, and obviously youth have a better chance of survival and have less comorbids. But I would like to hear perspectives from Kenya and Philippines, and also your perspective on why deaths were so high in a few other regions. Do you think it was because of the infectivity, or was it different strain of viruses, or do you think genetics also have a role to play?
If I can go fast, Dr. Troy, Dr. Muthoka here, I think you actually answered the question yourself. When you look at places like Italy, like Spain, where we had a lot of mortalities, and also the US and Britain, the comorbidities were quite played a quite significant role. We have an aging population in most of those towns, most of those countries actually, UK, Italy, Spain, and in most of the other countries, in other countries like Pakistan, as you have said, like and in Kenya, the population is youthful. We have a youthful population which has less comorbidities and risk factors for severe outcomes on COVID-19. Also, genetics. I think maybe genetics may play some role, and I am happy some organizations are looking at the genetics of people and how they relate to the infectious diseases and how infectious diseases take in some of the populations like the Hispanics and Caucasians. So I think as we move forward, we may realize genetics have a part to play, although that scientific evidence is not on the table, but that may play some role. Thank you.
Great. Dr. Troy?
Yes, thank you, Dr. Philip, for the inputs. For the Philippines, I think at the start, probably in March and April, there were really a lot of cases and deaths, and I think our healthcare system was still trying to cope with how to manage COVID-19, and then we became better at it. So we became more resilient, and our healthcare system was able to take care and manage the cases that were eventually going into the hospitals, those who were admitted to the ICU, getting ventilatory support. And we had a decrease in the number of cases eventually to the present time, where we only have around five or eight cases that are dying every day. But having said that, we still need to really provide for our healthcare system to make it more capable of accommodating all of these cases. What we've found is that epidemiologically, um, there are 90+% of cases that are relatively mild or moderate among those who are confirmed. And then we have around 3 to 4% that are asymptomatic. And then we only have like 5% or even less than 5%, which are severe or critical cases. So we're really now looking at how the epidemiology, the lie of the land of the diseases is coming about here in the Philippines. So we're just really getting accustomed to what the incidence of COVID-19 is and how many are really affected. And then we are trying to manage as quickly as possible those who are in the severe or critical stage. We have a lot of hospitals that are trying to take care of COVID-19 patients. We even have dedicated around 4 or 5 hospitals here in the capital, in Manila, to take care of these patients. So again, as I was saying, we're really trying to improve. We're trying to be more resilient in how our healthcare system can adapt to this COVID-19 pandemic.
Good. So another question that's actually coming on the screen right now, and I'm going to talk about it because we're still at the topic, is that how can we say that we've reached a herd immunity threshold when we aren't doing enough testing and we're still learning about COVID-19 each day? I think these are questions that keep coming up within the life fields. Would anybody else want to go first, or should I answer?
Yeah, I see his point that we really have a long way to go. We're still learning a lot of things about COVID-19 and how to really address its unique characteristics. It's transmissible. It can cause mortalities. The technology of how we can develop the vaccine will be quite unique compared to what we have gotten accustomed to. So I think Dr. Philip mentioned that in Kenya, you have been doing zero-prevalent testing. Here in the Philippines, we just started doing this zero-prevalence surveys, and we want to learn a lot from this so that we can know how we can better appreciate or acknowledge that herd immunity is actually present, and we can still try to find ways, what kinds of communities, what are the characteristics of these communities that might have a difference between those communities that might not have that high herd immunity. So we're still trying to develop the methodologies for this as we speak.
Great.
Okay. In Kenya, I don't think we can say we have reached herd immunity yet, and I concur with the colleague who asked that question. It will be quite some time before we can see any region of the world has reached herd immunity. There's some simple guide as to the way the question was framed. How will you know whether you are reaching the herd immunity? One of the guides is that when you are doing an unlimited testing in a sample of about 100 persons, and the positivity rate you are getting is 5% or less, then when you continue getting less positivity rates in your COVID-19 testing, 5, 4, 3, then you can start saying you are almost getting to herd immunity. Then to confirm this, you can go to the community and do community-wide sero-prevalence survey. But you see, the other challenge is we don't know whether these antibodies which you are going to detect in these persons are protective. These antibodies protective or not? Thank you.
Great. So I just want to add one point to what Dr. Philip said. I think the statement was made by me that Pakistan seems to have gone into or reaching herd immunity. And the reason why I say that is because we are continuing to test every day and the positivity rate is continuing to decrease on a daily basis. Still has not touched zero, but it is continuing to decrease on a daily basis. Deaths are continuing to decrease on a daily basis. So when rate of positivity is decreasing, there are less cases that seems to show that community might be entering into herd immunity. And herd immunity, like we all know, I really want to spend some more time on this because this is a question that keeps coming again and again. Herd immunity as varies according to place to place. It's not the same for every country. It's not the same for every region. It can even vary by postal code. So if there is a population that is reaching herd immunity, they're not getting more new cases on a daily basis, or at least they're not getting uh, going up the slope, their slope is actually going downwards, it does seem to show that there is a possibility that they might be entering herd immunity. So I'm going to stop it here. And there's another question that I want to ask everybody here is that other than COVID-19, because of COVID, a lot of our hospitals also had to close down to cases other than COVID. So there were conditions like chronic diseases like diabetes and hypertension who inadvertently could not make it to the hospital because they were overcrowded with COVID-19 patients. So we also saw a lot of deaths, at least if I look at it from a regional level, because of other causes of death as well, not COVID, non-COVID deaths just because they were not able to reach the hospital or they were not able to do proper medication on a routine basis because of the COVID-19 dilemma. So would you want to talk about that? Do you think a lot of these deaths are also attributed to non-COVID-19 and because services were brought down? Here I want to specifically talk about family planning. I know it's not a topic for most infectious disease people, but family planning levels came down massively because health services was stopped in a lot of countries, and it's a lot of experts are talking about that there will be a baby boom after COVID-19 because family planning services went down sharply, and similarly with other services as well. Same was the case for Pakistan. So, Dr. Troy and Dr. Philip, your opinion on this? Deaths as well as morbidity.
Yes, I think we took a hit uh, in how we will try to take care of our non-COVID-19 patients. There were definitely a lot of cases of diabetes, hypertension, cancer, and other kinds of diseases that weren't really able to continue their treatment as they had problems going to the hospital because the hospital was really turning them away. And this might have really contributed to the number of deaths. This is something that we're already planning to do research on and eventually try to come up with a good estimate later during the pandemic as to how many really are the casualties or victims, those who died due to the COVID-19, not really directly related to COVID-19 infections. So this is something that we're still trying to explore. And we keep on coming back to that idea that we're all quite vulnerable at this stage. So, Dr. Wajiha, if I can ask again to repeat your second question.
My second question was so the one that's just popping on the screen right now. It's with Pakistan almost 100% open. What is the prediction that if going forward, what measures need to be taken if once going forward to avoid a serious pandemic-like situation again? So this is not just for Pakistan, but let me rephrase this question to my panelists. If any country is moving out of the pandemic, or at least seems to be moving out and their curve is starting to flatten out, what kind of precautions do you think they need to take in order to avoid a second wave?
Okay. I think the avoidance of a second wave may not be something which will be in the offing quite soon, but we know when we have had previous waves, they have come because the globe has not gotten effective vaccines, and the citizens in those countries relaxed their public health measures in the control of this current infection. So to avoid a second wave, I think there are some things we may need to put as life abnormal, like the use of masks and sanitizing of hands and keeping social distancing. Now, when we come to the first issue you were talked about in terms of the deaths in the community because of reduced usage and access to healthcare in the healthcare facilities because of COVID, um, there may some of the deaths may have arisen because the citizens in certain countries, those countries, and were not able to access no more healthcare services. And as my colleague from Philippines has said, Dr. Troy, here in Kenya, we have developed some guidelines on how to continue within the essential medical services. In Pakistan, you rightly say there'll be a baby boom after COVID because family planning was not well, utilized. And that is not only the only issue. It is not an issue of family planning. It's because everybody is at home and you are there to get together. So that is bound to happen anyway. So when it comes to avoiding a second wave, that may be a difficult question, may be a difficult phenomenon. And there was a question which has also been posed there, whether the vaccines which are going to be utilized will be effective in the face of a possible mutation of the virus. They are going to be effective. What we know, the mutations are going to happen in the COVID-19 virus. So when you get the vaccine or you had been infected with the virus and you get some level of herd immunity, the mutated virus will not be completely different. That is my prayer from what is happening now. So you still have some bit of immunity, and if you're going to suffer, you're not going to suffer severe forms of the disease. You're going to get some minor forms of COVID-19 disease. So we should not be afraid of mutations because viruses, we know they mutate. Influenza viruses mutate, and that is why the globe develops a new influenza vaccine every year to take care of those small mutations which happen. So for COVID-19, let's use the vaccine which is going to be delivered by the globe. Then we will continue developing new vaccines using the new mutated strains. Thank you.
Okay.
Dr. Wajiha, if I may add.
So I have. Please. Go ahead, Dr. Troy.
Related to vaccination and the discovery of new vaccines, something that the Philippines is also trying to preserve. We want to continue with our public health programs. Aside from family planning, we are also looking at immunization so that we will try to avoid having outbreaks of measles, possible outbreaks of polio. And when the vaccine eventually comes, when the vaccine for COVID-19 eventually is developed and is already tested to be effective and safe, and there will be a mass vaccination, we have to have that kind of immunization mechanism, or our system to vaccinate children should be of high integrity so that we can deliver the vaccine to those who most need it.
Great. So I have with me Dr. Saad, but he is on the phone right now. And I'm going to float a question that will have a huge answer, and there's no right or wrong answer. But I'll go first with our panelist from Pakistan, Dr. Saad Khalid Niaz. What do you think countries could have done differently or will do differently to equip themselves for a better future in case a public health crisis like this happens again? So, Dr. Saad, would you want to go ahead and answer this question first?
Yeah, sure. Thank you very much. And apologies, I'm actually in an area where the signals are actually very poor, and This is north of Pakistan. Now, coming back to what we could have done better or what our response, I think when it all started, we had the viruses come mainly from Iran. And we had already stopped people coming from China. And then later on, people from other parts of the world came. So I think where I personally feel we could have played a better role from the government point of view is that we should have stopped the people who are actually were gone for for the religious visits. We should have stopped them there and we should have controlled that and not allowed them to come to Pakistan. So I think that would have been very, very useful, and then creating isolation centers within those areas where they entered from Balochistan and from the other borders. Similarly, we were a little slow in reacting to people who came from overseas. So there was a time when people returning back to Pakistan, like 60% of the flights were positive with COVID. The other thing that I think was lacking in our response was the fact that we did not have a very strong, coherent government policy. So there was a bit of a confusion. On one hand, we were told this is nothing to worry about. On the other hand, we were told to wear a mask and to have the social distancing and all that stuff. And while we were telling the people that it isn't something very serious, the impact wasn't coming. Similarly, the other problem was that, like, the province that I live in, we had strict lockdown, and I think that helped us, in my opinion, a lot because the city that I come from is the largest city of the country, and it has a population of over 25 million. So and most of the flights and people returning were coming to our city. And hence that lockdown really helped. However, the federal government had a different opinion. And then until the festive of Ramadan, the last 10 days of Ramadan, I think we were pretty okay, and then we opened up everything, and after we actually suffered significantly, especially because our health facilities are not as good as the Western or the developed countries. So we could have saved a lot more lives, in my opinion. I personally feel that the virus, over a period of time, somehow must have changed, or something has changed, because the weather and all those things are very similar in other parts of the world as well, including immunity. And I really find it hard to believe that our government or people's response in our country really was responsible for the results that we've had, which has been so far very good. We've managed to not have the kind of suffering that the rest of the world has actually seen. How would we go forward? I personally feel that, especially coming from a relatively, underdeveloped part of the world, our focus is not really health. Our infrastructure for primary healthcare almost does not exist. And so we need to invest really in health. We need to invest in education. I can tell you that I started traveling from the south end of Pakistan, and I'm actually literally in the north end. And trust me, there is no social distancing at all. There is no mask wearing at all. I haven't seen anyone literally. And you can take it as a joke, but when we were wearing masks and we got out at a place, people thought we had COVID. That's why we were wearing masks. Whereas nobody else was wearing masks. There's absolutely no social distancing in Swat, which is in the province of KPK. I went to Islamabad, and there again I did not see any real social distancing or mask. And so I feel that in Pakistan, really, we need to invest in health. We need to a lot more in infrastructure. We were exposed because we had very limited ventilatory supports. We had very limited technical support, logistic support, all. So we need to work on that, and these kind of things probably, they do not occur every decade, but nevertheless, we need to be prepared. The world has become small, so disease can travel from one part to the other very quickly compared to, like, for example, Spanish flu, when things were different, when traveling was different. Today, traveling it's become so easy that disease can go from one place to the other, and it's very difficult for any country to stop it. But I think, the most important thing here is to spend more on the health, infrastructure, and to have a coherent response from the government. And as far as our response is concerned, I'm really not convinced that anything that the people of Pakistan or the government of Pakistan really has done which has made the difference. There is something else that has happened because the virus suddenly doesn't affect people. It's very mild disease if they have it. And so there are a lot of people who have it, but testing has gone down. And so there are a lot of factors. People don't want to go to the hospitals. We have learned to treat. The other thing that I think was very important for me is the role of social media. I think the negative role of social media was much more here than the positive, because, for example, the chloroquine story, it was just, it went berserk. I mean, chloroquine disappeared from the market. Other medicines were being used right, left, and center. We were told this is the magic cure, this is thing, and normally when we deal with diseases, this doesn't happen. People don't even find out until phase 3 trials are done, until we have good evidence in support of a treatment that we are offering to our patients. So all those norms were actually completely challenged and also ignored. And I think, those are the things we need to really focus on. That's what I would say about these 2 points that you mentioned.
Right. I just want to add one point here, and before I give the floor to Dr. Troy and Dr. Philip, I think for a future we need to start investing in primary health care. We all are investing in tertiary care hospitals and clinical cases, but we need to take a top-down approach, maybe a bottom-up approach, maybe, and start investing more in primary health. Because unless you look into primary health basic issues, this maybe pandemic might just not have risen had we focused in a good time period and had we, curbed it at its best part. Dr. Philip and Dr. Troy, do you want to add more to this question? Because this was a very open-ended question.
Yes, I want to concur with you. We need to start moving away from tertiary kind of clinical care, because when we invest a lot of resources there, it's as if we are telling our people, please get sick and come, I treat you. So we should change that scenario and invest in primary health care. Let's protect, let's prevent, let's enhance health at the household level through instituting primary health care ideals. When you have a robust and working primary health care, then you will have a system where you can communicate with the public, with the household members at ease, because the structures will be there. Then the other thing we need to do is to strengthen our healthcare systems. We need to strengthen surveillance, both for local pathogens and for any novel or emerging or even re-emerging pathogens. So it is very important to strengthen surveillance. Let's put resources there. Let's also strengthen our advocacy. How are we going to pass information to the village, to the lady at the village level, so that they get the exact information we want them to get, and we give them information on what to do in case of a problem and where they can go for help and who they can contact in case they get help. Now we're having a lot of stigma with COVID-19. Where do those people who feel stigmatized, or those people with mental issues, we need to give them an option, whether they can go virtually on a virtual platform to get assistance, or they can call some number. We need to strengthen and put those structures in place. We need to establish a robust preparedness platform in all nations. And preparedness should not only be for exotic, that is novel pathogens like this. Preparedness should also be for health events within our nations. And within this preparedness, the ministries or the officers charged with the responsibility of health for others need to have a contingency fund always ready to be called upon to make sure at least the response to events like this are prompt and we don't waste any time. Thank you.
Great. Nicely summed up. Dr. Troy, your views, please.
Yes, thank you for sharing your views, Dr. Philip and Dr. Saad. I also share the same insights and share the same conviction that we really have no way to go but to really prioritize primary healthcare. And speaking of primary healthcare, really have to have a systems approach to preserving our public health system. We just cannot look at the hospitals, but we also have to look at our cadre of healthcare workers in the communities, in our health centers, and we just have to extend our reach towards all the people that will be prone or will be vulnerable to COVID-19. Just early this year, we were really about to embark on the start of our universal healthcare program. We just passed the law in 2019, and we were about to undertake massive reforms in our healthcare system. It's just sad that COVID-19 became our number one priority, but it's also sort of a blessing, so that we have this kind of challenge that will help us be more convinced that we have really to move forward. We cannot go back to what we were before. We had from 30 years ago, we were really very fragmented because our healthcare system was devolved. We had a decentralized form of government in the early 90s. And now this is really something that we have to keep in mind so that we can leave this as a legacy to the future generations. And I have that kind of persuasion that COVID-19 is really a milestone year for us here in 2020 and probably in 2021, so that we can really come up with different avenues of collaboration between countries, within the country, between our international health agencies, so that we can learn as much as we can, not just the technical part, how to treat, how to manage, how to come up with good vaccines or good medicines, but also to really come up with a good spirit of communication, coordination, and really we need to collaborate closely across all countries. So this is just the start. COVID-19 is just a way for us to shock ourselves maybe into realizing what we may have forgotten a long time ago, that it really begins from what you mentioned, Dr. Wajiha, that it's a bottoms-up approach. We really have to start from what the needs are of our communities, and so that we can better serve the health needs of our citizenry in each country.
Great. So we have a couple of questions popping up on the screen, and all my panelists can answer this. So we have a question, and they're asking, what is your opinion on wide-scale lockdown versus a small-scale community lockdown? Which one do you think is more effective in controlling the spread of the virus? Dr. Saad, were you able to hear the question? Great. So,
if I could go,
both the options have to be done at the same time. They need to be exercised depending on the percentage of the population affected, on how common it is, and how people are actually following the instructions. I think a lot of factors have to be taken into account. Smart lockdown or a selective lockdown would be good in places where you know that there is a particular area where you have a high prevalence, and so what you do is you lock that down so that community is not mixing out so much with the rest of the community, that hence you try and stop it that way. Now, in the larger lockdowns, obviously the downside of the larger lockdowns is economical downside. And in countries which are relatively poor countries or developing countries, it becomes a big problem because as it is, a lot of population is living below poverty line or just about there. And so it becomes very difficult for them. So you need to get the right balance there. But in my opinion, as I said, in certain areas, you would have to have complete lockdown, and in certain parts you will have to have selective lockdown. But most important was initial reaction. Initial reaction, because this is a virus that started from two places really. As far as for us, Iran was the biggest area where we got it. The largest number came from Iran initially. So we could have been a little bit more proactive, and maybe we could have stopped it and contained it. And you can't stop this disease. No matter what you do, it seems like, looking at the examples of a lot of countries in the world, but having said that, if you slow it down and allow a lateral spread in a controlled way, then the medical system would be able to sustain it. And our worry in Pakistan was that if this had gone any more than what it did, in fact, we almost collapsed. At one time when we had, when we reached the 300 numbers of deaths a day, it was very difficult for the medical system to cope up with it. And that could have been prepared much better because we had time and warnings coming in January. But having said that, obviously, this was something that we all have experienced for time, and the medical community also had to learn. This is hands-on learning. So that's what my response would be. I don't think there is one right or wrong answer. It has to be applied to different populations in a different way.
Okay. I have another question, and this is directed for Dr. Troy specifically. So we know that the Russian vaccine is going to be an RNA vaccine, and people are concerned, and we have a lot of questions that if there's a mutation in the COVID-19 vaccine, do you think that Russian vaccine will not work?
I think ideally we should have a complete understanding of what we are supposed to develop. So if we have the mutation that might be occurring, and if it's very prevalent, it should be considered as part of the vaccine. It should be considered as part of how we will develop the vaccine. So we really just have to apply our knowledge as to how we can appreciate the extent, the incidence of that mutation. So the short answer is yes, and we should just be considerate of how the vaccines should be customized as to, like the influenza vaccine. There might be different strains that might be occurring in different parts of the world. So we just have to come up with probably different versions of the vaccine or different kinds of strains that will be included in the vaccine that will be distributed to the different countries.
Okay. Okay. So I have another question. Do you think going forward, we should start planning vaccines for future pandemics or epidemics? Do you think we should have a global unit dedicated just for this as a lesson learned?
Okay. Yes. I think it would be a wise idea to have some candidate vaccines for even what we may think may be future candidates for pandemics, like what you're seeing in China now, the H7N9. So if we can have a candidate vaccine for influenza viruses, then we have a candidate vaccine for coronaviruses, which are prone to give pandemics, then that will be good. But then the other thing we need to think as a globe, we need to think and to start going biotechnology, so that we don't take 6 to 9 months incubating a virus for it to grow. Let's look for ways of making the virus grow faster so that we can get vaccines out there faster. It's expensive. The initial investment may be expensive, but that may be the way to go. Thank you.
Okay. So we have another question on the screen. I know it's been answered multiple times, but if anybody wants to answer it again, what can you say about rapid testing? Are they indicative of COVID-19, and what is their accuracy like?
Here in the Philippines, we actually have tried to do away with the rapid diagnostic tests. So we are trying to focus more on the gold standard, which is RT-PCR testing. Rapid diagnostic tests, though, have a special place in the conduct of sero-prevalence surveys. So it can be useful for us when we want to estimate those who are infected or those who might already have immunity in the community. But as a standalone clinical diagnostic test, it has very, very limited use because of its highly variable accuracy. Sometimes the accuracy might be as low as 50% or maybe lower. So it seems as if you were just trying to do a coin flip, whether it's a heads or tails. So I think we could fare better with the coin toss compared to using the rapid diagnostic tests as they are now available.
I can put a comment there on the rapid tests. What you need to ask yourself, this rapid diagnostic test I'm using, what does it detect? Does it detect the viral parts or does it detect antibodies? If it detects antibodies, then it may not be useful in detecting the illness in the acute phase. The antibodies start growing after about the 5th, 6th, going to the 10th day. So if they are serology-based rapid tests, then they are not useful. They are not useful. Let's go to what Dr. Trey has said. And on a question directed to me on my experience working with COVID in the Ministry of Health, Kenya, my experience has been wonderful. In the initial stages, it was very challenging, but when we got our foot down, as I guided the ministry in taking measures to control this COVID-19, so far I have enjoyed the work we have done, and it has been good. So far, so good. Thank you.
Great. Dr. Saad, I have a question for you here.
Just wanted to add something.
Gigi, please go ahead.
One of the points that have just been made, I think as medics, we learned, obviously we were learning. In the last 10 to 12 weeks, we've learned and treating the patients, we understood which were the patients who needed to really come to the hospital, and obviously giving the medications early and authentic medications rather than just going for everything that's expensive or that's not proven. And I think it has been a very very difficult period, but an experience that has taught a lot of things to us. You were asking a question, please.
So one of the questions that I received was again on herd immunity. Do you think nations are entering within herd immunity if the number of cases are going down on a daily basis?
Being reported that
yes,
we don't have the positive. I think that is not safe. People who are positive, who have higher risk, are actually now not really. A lot of them are not testing. People who have already had infection are not testing again. So that was also part of the initial management, which obviously is not being recommended anymore. Herd immunity would require 80%, 90% of the population to have been infected by this virus or affected, or and I don't think we've reached that level at all. So, but I can tell you something is very strange about the behavior of this virus in Pakistan. I can only talk about Pakistan because the numbers of the patient, the number of people who got infection and who not really got severe infection was low initially also, but the ones who were getting serious has actually gone down over a period of time, but has become much better. And to be honest, the treatment has really not changed in the last 12 weeks. And so I feel, although this is not my field, but I feel there is something that, as we were just talking, the virus, the viral mutation, the virulence of the virus, or whatever, which is something that the experts can answer. But there has to be something else, because nothing changed in our country otherwise. We can claim so many things that we did smart lockdown, we did this, people did not, and this is a fact. And having, despite that, we have really not seen what is being seen in the rest of the world. So there has to be something in the virus. And I hope that at some stage we will find out. I'm sure from other countries as well, it's not ours.
Great. I think Dr. Philip wanted to add something here.
Yes, I just want to say, as WHO has guided, when you start getting the reduced positivity from your tests below 5%, 4%, going to 2%, then you get 0%, then we can say probably that community has achieved some herd immunity, but we need to go further and do a sero-prevalence survey in that community to find the antibody titer levels. We can't just say that maybe the viable virus to be transmitted in that community is not there. So if it is not there, then you'll not get new cases. But then if you have to say, yes, this community has herd immunity, I think it would be good to do a population-based sero-prevalence survey to be sure.
Great. So we have a lot of questions piling up. Another one is from my side. Do you think, because all of you are working with your respective governments in your respective countries, do you think going forward there should be a separate fund dedicated solely for protecting the population from future epidemics and pandemics? Do you think you'll be advocating for that with multilateral and bilateral donors, both at a global level as well as your country level? Again, it's for all my panelists. Anybody can answer. Who wants to go first?
Yes, I'll go
Dr.
first.
Troy
Dr.
wants to go
Wajiha.
first.
Yes, yes. Actually, here in our country, our president has already talked with the presidents of China and also Russia. So it's more of a bilateral arrangement where we'll be trying to participate in the clinical trials of their candidate vaccines here in the Philippines. So as for the future, I actually work with some legislators, and we are now trying to put our minds to come up with legislation so that we can have more budget for more facilities and organize sort of like a CDC here also in the Philippines so that we can quickly respond to these kinds of biologic events in the future. So a while ago, we were talking about if we were to organize something like a global organization that will lead the development of vaccines in the future. We also need to develop that capacity in each of our countries. So there's really a lot of investment that will be coming in, not just for the laboratories, but also for epidemiology, for our healthcare workers to focus on infection prevention control, continuous training, and continuous retraining and refresher courses for our healthcare workers. So it really has to be all factored in. It has all to be budgeted. And if our doctors, our healthcare workers are also knowledgeable about the process, they should be a part of this. They should be made partners as they are important stakeholders in how we will try to provide the funds. In this present Congress that we have already enacted one piece of legislation where we already augmented the budget for our healthcare system. So we are now in the verge of passing the second kind of package for our healthcare system. So we hope that we can only improve our systems, that they will be sustainable in the future, not just for COVID-19, but for other kinds of viruses or any emerging disease that may happen.
Great. Since we have a lot of questions coming up, I'm going to limit one answer per question from each panelist. So my next question is that do you think countries should close down their borders at the very start, even if it's not globally being restricted, as soon as an epidemic is announced in another country? For instance, let me just rephrase the question. For instance, there's an epidemic in the US. Do you think Pakistan or Kenya should close down their borders so that it doesn't become a pandemic? Dr. Saad, if you would like to answer.
I think that may not.
Okay, Dr. Philip.
Crossing borders is one of the closing borders is one of the measures of avoiding the spread to other countries. But closing borders early, you need also to consider the international health regulations and what they say. You have also to close the borders bearing in mind the international obligations which you have to meet. You are not living in an isolation. You may also close the borders, but then the problem comes to you. You know, it may be counterproductive closing the borders early. You may feel you are protected and you don't actually prepare for the eventuality. Then you are caught with your pants down. When on a question like, are we prepared for future pandemics? Nations should have learned now. You know, initially, nations never used to prepare for public health events like this. So this realization of what has happened should make governments put more emphasis on their preparedness levels so that in future they are ready. They are ready. Anytime they have a team, they have contingency resources to counteract any future outbreak. They should be ready now because they have learned a lesson. Let's put money in public health. Let's not put all the money in clinical care. Thank you.
Great. Dr. Saad and Dr. Troy, I have a question for you. I know we've talked about this, but people want to hear again that if a disease is landing at a healthcare provider, that means that we already have failed the system. We've already failed that public healthcare system. So shouldn't it be the responsibility? Should it be the responsibility of that hospital, or should it be the responsibility of the government that such cases just don't land up in hospitals? Again, we're talking more about public primary healthcare as opposed to clinical tertiary care. How do you think going ahead you would be working in your respective countries to advocate for more stronger primary healthcare systems? Dr. Saad, would you like to go first, please?
Yeah, I think pandemic or any other problem which are, which have a high prevalence, that you can only work if you have a primary care system. If you don't have a good, strong primary healthcare system, you'll not be able to address major problems. I'm talking about something that's large, like something that seems like sexy. But this is a very good point for us to learn that we need to provide health at the lowest level so that understanding, knowledge, and even following instructions would become better. If we had a good primary healthcare system, we'd be able to prevent a lot of other diseases, just not about COVID. So yes, we need to invest. Countries like where I come from, we need to invest more on health than anything else along with education. That's what needs to be done, and when that is done, things will change in our country.
Great. Dr. Troy, would you want to add something here?
Yes, yes. Thank you, Dr. Wajiha. Just quickly, in an ideal setup, in an ideal world, there shouldn't be a divide between tertiary care and primary care because we are all part of a healthcare provider network. For universal healthcare, what we intend to do is to have a good referral and back referral system so that those who are in tertiary care will actually know what the public health priorities are. And then the primary care would have to step up with their clinical skills also so that they will know when or how to refer, not just for COVID-19, but for a lot of other diseases. So we really have to see this as a collective whole.
Great. I've got one last question. It's more of a visionary question. Again, there's no right or wrong answer. So in a post-COVID-19 world, if each of my panelists could briefly give me just 2 suggestions. So I'll go first with Dr. Philip, that in a visionary post-COVID-19 world, what 2 major changes would you make or recommendations?
For Kenya, I would wish we completely implement primary health care. That is one. The second one is we need to have contingency resources to respond to pandemics or even outbreaks within countries. Then number 3, we need to strengthen our healthcare systems.
Good. Dr. Troy?
Yes. I heard that a lot of college students are now planning to enter medicine and also probably enter public health. So it's going to be something that will excite us to learn that we really have so much to do. We actually have a broken healthcare system that needs a lot of fixing. So we need a lot of people. So kudos to all those who are joining this bandwagon, that we will have to have more people contribute the great minds and also come up with good solid strategies as how we can better improve our healthcare system. It's not just for COVID-19 or in the eventuality of a pandemic, but it has to be the business as usual kind of disease management, both at the primary care and at the tertiary care level. And also another suggestion is for us to use and maximize technology. We have so much to offer, and these have to be applied in public health and also in clinical care.
Great. Dr. Saad, would you like to summarize 3 points going forward that you would like changed?
Yeah. Okay. One of the things that I learned from this is that economy and health go hand in hand. When there is going to be a major health issue like this, it will have a major impact on our economy as well. So we need to have good health to have good economy. Yep. Okay, and I would suggest that I think now that we've faced this and possibility of having something like this again, there should be a system, a team ready to actually to address this issue and involving people who are actually real stakeholders there, and strengthening your health systems is what we need to do. If we can't face this, but at least we can minimize the trauma that a lot of countries have had because of this.
Great. So we've had a very productive session for today. Any take-home messages that each panelist would like to discuss before we call it a day today? Let's just keep it short. Time is short. Dr. Troy, go first. Yeah.
Yes. For me, I'd like to thank Getz Pharmaceuticals, Dr. Wajiha, our panelists, Dr. Philip and Dr. Saad. It's really a pleasure to collaborate and also to learn from each other. So I guess my take-home message is for us to continuously learn from what's happening to us. Each of our countries are unique. Each of our societies have their own kind of culture, but we are all in the same fight against this common virus. So we just have to stick together, and hopefully we can see the end pretty soon.
Great, thank you. Dr. Philip, would you like to go next?
Okay, first I want to thank my colleagues, for the panelists, for the good contributions we have made in this, and the listeners. And my first point is primary health care is the way to go, number one. Number two, preparedness not only for pandemics and for outbreaks, but also for non-communicable diseases. Let's prepare so that we can make sure we take care of our populations. Then governments all over the world need to allocate enough resources to healthcare, and let them not assume healthcare means only care in the ward. Let at least a big chunk of that go to primary healthcare. Then I challenge the industry, the medical industry, to go technology. Let's create mechanisms of biotechnology to produce vaccines at a lesser period. Thank you.
Great. Thank you, Dr. Philip. Excellent points. Dr. Saad, the closing remarks from your side.
First of all, I want to apologize because I'm at a place where I could not actually be on the call alone, so apologies. Thank you for getting this forum together. I think what we need to learn as humans is to actually place humanity and human life above everything else. If we haven't learned that from this pandemic, then I'm afraid, in my opinion, we haven't learned anything. We've learned that the world can collapse just because of small disease that spreads in such a horrific way and causes so much destruction. We have a World Health Organization. The World Health Organization's job should be to actually address these issues regardless of cost, regardless of whether we are in the developing world or the developed world. This is in situations like this, in crises like this, I think humanity should rise above everything else and we should help each other, learn from each other, but above all, whoever is better in technology should support so that the whole world can benefit from it. And it should not be about monetary benefits. It should not be about power, which is what we have seen in the world so far. So if the world focused on humanity, I think we would be able to fight these kind of things much better. Thank you.
I think excellent remarks from all of my panelists. I'm going to call it a day today and I will wrap up. But our take home message, majorly through this public health seminar today, has been reinvesting in primary healthcare, restructuring of health to have a bottom up approach, and also to have global sharing so that, for instance, if God forbid a new pandemic comes up, we can develop vaccines and preventable measures in a much shorter period of time. Another thing that I would like to point out is that without a multidisciplinary approach, things can't move ahead. Economy was halted because of health. Education was halted because of health. So unless we start investing in health and economy and everything combined together, I don't think we can go ahead and reach the kind of world that we're talking about. Thank you, everybody, for joining us. And good evening, good night, and good morning from each part of the world where you're all watching from. Thank you.
Thank you, and all the best.
Thank you.
Thank you.